Sir.
Okay, that's it. Yeah, people are joining, so we'll wait for another couple of minutes and then we'll start. Okay.
Okay.
Bobin sir, good evening. Actually, KKR sir has also joined now, and we are having now almost 106 participants.
Okay, then we can start with it.
Yes.
Okay, sir.
I think by the time others will keep on joining, right? So we are 100 people have already joined. We start on time. So, okay. So good evening, all. Welcome to the 40th Hamburg PG case presentation. Today we are having a different format instead of one long case. Since the exams are approaching, we thought like we'll give more importance to short cases as well. So today we'll be having three short cases will be presented by three different postgraduates from different parts. So I request Munir and Uditya to take over the proceeding. Over to you guys.
Thank you, Bhavan sir. Thank you. This time, ISMBO IMO along with Ambok, we are conducting this
Recording in
monthly case
progress.
presentation as in a different format. We'll be having three short case discussion. Name this session as Step and Shine, followed by an OSCE session. So every case will be giving a maximum of 30 minutes, and after the three cases, we'll move on to OSCE session. So, Dr. Udiptya, anything else?
Yeah, so we have three presenters. I would like to just introduce them to the audience. So case one will be presented by Dr. Aishwarya, who is our trainee from Apollo Chennai. Then the case two will be presented by Dr. Shriram, who is from MBR Calicut. And case three will be presented by Dr. Anisha, who is from Manipal, Bangalore. And we have our two prestigious examiners today, Dr. Vinayak Maka, who is Professor MS Ramaya Medical College, Bangalore, and Dr. Krishna Kumar Ratnam sir, who is the professor in Meenakshi Mission Hospital, Madurai. So without further delay, I think we can start with the first case. Dr. Aishwarya can proceed and start with the permission of the examiners.
Good evening, sir. Can I start my presentation?
Yes, Aishwarya, before we start, since this is going to be a short case format,
Yes, sir.
and in the DNB, almost all your cases will be like a short case format only, so it's better to rehearse. So in about 2 to 3 minutes,
Okay, sir.
please give the concise, positive, and the very important negative history, which will help to bring you to a direction, and you can give 2 or 3 differential diagnoses. And in the next 3 to 5 minutes, please give all the salient general and the local system examination that you did for this patient. And so that by in about 8 or not more than 7 or 8 minutes, history and examination should be over so that you can start discussing the differentials. Okay?
Okay,
Yeah.
sir.
Go ahead.
So here we have a 23 years old male, software engineer by profession, a resident of Chittoor, AP, who presented with chief complaints of pain in the right thigh region for 4 months and swelling over right thigh for 3 months and cough for 1 month duration. History of presenting illness. Patient was apparently normal until 4 months back. Then he developed swelling in the right. Then he developed pain over right mid thigh region, which was intermittent and mild in intensity, majorly present at night. It was partially relieved by analgesics. Pain does not cause any limitation in activity. He also noticed swelling over the front of the right mid thigh region since 3 months, and which was initially in the size of a small pebble and has now increased in size, extending from the mid to lower right thigh region. History of dry cough for 1 month present. There was no history of any shortness of breath or chest pain, no history of any fever, trauma, any other deformities, no history of weakness, numbness, shooting pain, or any difficulties in walking. There is no other history of similar swellings elsewhere in the body, no history of bone pain apart from the right thigh. There is also no history of any weight loss of appetite, and night sweats. Past history, no comorbidities, no any past history of tuberculosis, history of radiation or malignancy in the past. There is also no history of malignancy in the family. Personal history was normal, bladder and bowel, mixed diet, no addictions. Treatment history with the above complaints, he was evaluated outside hospital, managed initially with painkillers. Later on, as the swelling was progressive, he was evaluated in an X-ray followed by MRI of right thigh region and PET CT whole body and a needle biopsy. After that, he was referred to our center for further management. To summarize, here we have a 43-year-old male with no comorbidities who presented with complaints of dull aching pain predominantly at night time for 4 months, followed by progressively increasing swelling over the anterior aspect of the right mid to lower thigh region since 3 months, and history of dry cough for 1 month. With the above summary, I suspect a malignant tumor of the right thigh region. My first differential diagnosis will be primary malignant bone tumor, and other differentials, though lower probability, might be soft tissue sarcomas or any primary bone lymphomas, plasmacytoma.
Aishwarya,
Yes, sir.
so I have only very few questions to ask you because why at all you're thinking of malignancy? Can't this be a hematoma? Or can it be something else, spontaneous hematoma or any other problem? So why malignancy? I need you to give me about 2 or 3 points, and then why you precisely say your first differential diagnosis as a bone tumor.
So malignancy because of short durations of 4 months, and because of the age of more than 40 years, there was no any associated history of any traumas or fever or anything to suggest any non-infective infective causes or non-malignant causes. I'm suspecting bone as my primary bone tumor as my first differential diagnosis because it was he had pain first, which was classically present at night and not relieved by analgesics, and following which he developed swelling, sir.
You feel it is a progressive swelling over the last 4 months, so that is the reason for malignancy.
Yes, sir.
With no other inciting factors.
Yes, sir.
What is very characteristic of malignant pain versus non-malignant pain? 1 point. Then we'll go to the next question.
Malignant pain, it is not. It is more at night time, and it is not
by analgesics and more at night. That's all the answer. Good. So the next point is why bone swelling? Why did you think of a bone tumor?
So my first impression was bone because it was pain first followed by swelling. So in soft tissue sarcomas, usually there'll be swelling first followed by pain, and also any traumas or infection.
Okay, so now did this patient specifically say this is a weight bearing bone? So did this patient say that while putting his limb down and while weight bearing he had more pain?
No, sir. He says he was not able to attribute the pain to any of his activities. He says it was not like aggravated by specific activity. He was able to walk, do all his routine activities, and he was.
What do you think will happen if it was a bone pain compared to a soft tissue pain? At least in theory and what we frequently see in practice.
Bone pain should aggravate with activities like any weight bearing,
Here,
like
this
walking.
patient you say is having pain more at rest, even in the night. He is not able to get a clear temporal association with movement or weight bearing. So yes, all these things can happen either ways, but I think one way of looking at it will be unable to even put their weight on that particular limb, or while walking, if pain increases, you feel the weight bearing bone is already affected. Whereas if the pain is not really related to that and is more located around the swelling, then you feel that this could be a soft tissue. But this is not an absolute history. You may have to just keep it in mind. So here you have a 43-year-old male.
Yes, sir.
So what are the differential types? So you feel it could be a bone tumor or it could be a soft tissue tumor. You said it could be plasmacytoma. So what is the average age of plasmacytoma
Sir,
in
it
the
is
male?
usually at after 50 years of age, sir. Because he was telling mid-thigh region and all that, I just gave it as a differential diagnosis at the end, sir. Lymphoma,
I would
primary.
like to, I mean, what I would say is try to, even in the exam, this is for all the candidates who are sitting here, you are not compelled to give 8 or 10 differential diagnoses. That means you can give anything. You can give soft tissue melanoma, you can give lymphoma, you can give plasmacytoma, you can give a lot of differential diagnoses. Whatever you think is very common. So today you're sitting in the OP, you have a person who says he has a right thigh swelling, which has been progressive in the last 4 months and associated with pain, not, and there is some malignancy diagnosis given outside. What will come to your mind first?
Primary bone tumor at this age.
Primary, some soft
Some
tissue
brain,
tumor.
soft
It could
tissue.
be either from the soft tissue or
Soft
could be
tissue or
from the
the
bone. There is a
bone.
tumor.
Yes, sir.
That's all right.
Yes, sir.
You are not forced to give other differential diagnosis.
Okay, sir.
Okay. This is just, since we are all going for exam,
Yes,
I'm
sir.
just giving you those points so that you don't try to set a trap for yourself. Now that you told me plasmacytoma, if what in presentation, forget the age of the patient.
Okay, sir.
Patient comes to you with a swelling in some part of the body, presenting as a progressive soft tissue swelling around a particular area in the body, you feel that this can be a hematological neoplasm. See, I've told you the name hematological. Hematological means it could be myeloma, could be lymphoma.
Yes, sir.
The presentation is like a soft tissue tumor in one particular location around a particular joint in the body. If that history, then you bring your third differential. Which joint and what kind of presentation is it?
Sir, history you are asking, sir, like what will be the possible?
The same presentation,
Okay, sir.
a progressive swelling around a particular joint
Okay, sir.
or an area in the body. I told you don't unnecessarily bring hematological diagnosis right now. Let the examiner ask you.
Okay, sir.
But now I am contradicting my statement. I'm telling you, if I were to ask you, I just asked this question because you brought this in. Around which joint or which area of the body, if a patient comes with a progressive enlargement of soft tissue and bone, you will think that I have to think of a hematological neoplasm.
Mostly around the spine regions.
No. Spine is common. Spine can. Do you think you will be able to find a soft tissue spine in clinical presentation as an enlarging soft tissue swelling?
No, sir. And otherwise, it will be mostly in the diaphyseal region, sir, or
In the adult patient.
adult
So
patient.
if a patient comes with a progressive soft tissue or a bony swelling around the shoulder area, that you also have to have a third differential diagnosis of a hematological malignancy, usually around the shoulder area. Okay. That's where sometimes isolated plasmacytomas or even lymphomas can present. This will be there in the older Devitas. Okay, so if you have some examiners who come, my senior examiners used to ask that question. Okay, please go ahead with your salient examination.
Patient general examination, patient was comfortable, ECG PS1, his vitals, temperature, BP, pulse, respiratory rate, saturation were all normal. His height was 170 and weight was 80. BSA.
Good. So I accept all this is normal. Straight question. What does your vitals have anything to do with the type of sarcoma a patient is having? Not the BP, pulse, temperature, that I will come to you again. Tell me about the skeletal system and sarcoma. What is the association?
skeletal system, any multiple exostosis or any other bony swelling
Okay,
elsewhere?
very good. So secondary sarcomas which come out of the bone due to pre-existing bone disease
Yes, sir.
in the adult,
Yes, sir.
accepted. Height and sarcoma, quick answer.
Sir, taller stature is more associated with osteosarcoma, sir, and
Very good. Excellent. So taller people are more prone for osteosarcoma. And what is the reason? You want to give us or you want to guess?
Sir,
What will happen to taller people who continuously grow tall? Where is the osteosarcoma?
in the metaphyseal region, sir.
Of the bone.
Metaphyseal region, sir.
Metaphyseal region. So the AP and the metaphyseal regions are the ones which consistently grow, right?
Yes, sir.
So you have a hypothesis that these people have a faster growing metaphysis, and from that area that can stimulate. That is one of the hypotheses. And that's the reason also why osteosarcoma is more common around which age group?
In the pubertal age group, sir. Due to the growth spurt.
Wonderful. Due to the growth spurt. So taller people having and the osteosarcoma coming around the pubertal time, both the reason is because it is due to the spurt in the bone growth. Very good. Now you come to the other vitals. Sarcoma vitals. What are you going to be specifically looking for? Let us say this is a young child coming with a thigh lesion.
Okay, sir.
So what other thing in the vitals you want to really look at this patient and say that, oh, okay, this patient has this, so I call this dash. Sarcoma fever. I'm coming straight on to you.
Ewing sarcoma, sir.
Very good. So B symptoms are common
Ewing
in Ewing sarcoma or sometimes primary lymphoma of the bone.
Yes, sir.
Right?
Yes, sir.
Okay, very good. Your general examination doesn't have anything to contribute to your findings, right?
No, sir.
Yes, please go to the system examination. What did you quickly see?
Sir, at the right lower limb, attitude was he was lying in the supine position, extended. There was mild external rotation. There was no any bony deformity or no apparent shortening of right lower limb. There was a single ovoid swelling, ill-defined margins, approximately 8 into 4 centimeter over the anterolateral aspect of the middle third of the right thigh. It was approximately 6 centimeter above the right knee joint, and surface appears smooth. There was also a 0.5 centimeter scar present over the skin on the anterior aspect. There was no sinus, ulcers, or any visible pulsations. There wasn't any obvious muscle wasting, lower lip edema, or paralysis.
Aishwarya, short case, I will tell you one thing.
Yes, sir.
Just learn this tactic.
Okay, sir.
For this patient, I would just say patient was examined in the supine position. Does the patient, do you feel it is coming from the muscle or from the bone?
Sir, it feels like, I mean, it looks like it's coming from the bone, sir.
You should be clear. Don't be doubtful when you're presenting to the examiner. Is it coming from the bone or is it coming from the muscle?
It's coming from the bone, sir.
So you feel there is tethering. So you should say that I found in this patient examined in the supine position, I found a 8 into 4 centimeter hard bony swelling coming from the right thigh region. That's all, which is about 6 centimeter from the knee joint without involvement of the joint spaces. And there is a scar present over the
anterior aspect.
And then you go to the next findings.
Yes, sir.
That's all. Okay. So here is no inspection palpation. You're doing a short case.
Okay, sir.
So it's a 2 centimeter on examining the patient in supine in the position with the limb turned laterally. There is no shortening. I was very happy that you said that. Many people miss that. So if there is a bony lesion and there is a fracture, obviously there'll be shortening of the limb, which many candidates miss. So you found it. Very good. So just say that this patient had a hard bony swelling 8 into 4 centimeters in the right thigh region, probably arising from the bone. So there could be two possibilities. This may be something in the muscle or it may be something in the bone. How do you differentiate a muscle tumor from a bone tumor?
Sir, the swelling was very hard and it was not mobile, sir. And the skin was pinchable and it felt like it was arising from the underlying bone, sir. It was fixed to the underlying bone.
How else do you define a muscle swelling? What happens to a muscle swelling and how do you clinically say that this is coming from the muscle?
Sir, when the muscles are taut, the swelling becomes less prominent and less mobile, sir.
So there are two things. So if the patient has a pure tumor which is coming from above the muscle, it becomes more prominent on putting the muscle into contraction.
Yes, sir.
Whereas a mobile swelling, if it becomes more fixed when the muscle is putting into contraction, it is coming from within the muscle.
Or
And if the swelling becomes less prominent on putting the muscle into contraction, it is probably going beneath the muscle and also tethering with the bone. So this could be involvement of periosteum by a muscle tumor, or it may be a bone tumor that is coming out with a soft tissue component which is staring at your face. So both possibilities are there. Fine. What else? You have looked at sensations, you have looked at all that. So why did you do all that?
Sir, to see if there is any nerve or involvement or any neurovascular structure involvement, sir.
So why is it important?
Sir, it helps in our management to decide the line of therapy, sir. I mean, involvement of all these neurovascular structures might
One line
be
answer.
relative contraindication for limb salvage surgery.
Relative to sometimes absolute contraindication to a limb salvage surgery, unless you are able to reconstruct everything, right?
Yes, sir.
Now, why did you palpate the lymph nodes?
Sir,
Does osteosarcoma spread to lymph nodes?
no, sir.
Which are the sarcomas that can spread to lymph nodes?
Sir, rhabdomyosarcoma, angiosarcoma, or clear cell sarcoma, epithelioid sarcoma, synovial.
Very good. So these are the ones which normally spread to the lymph nodes.
Yes.
So your patient, in case, let me say that this is a soft tissue sarcoma of the, and then you're also finding a firm lymph node, and you feel it is metastatic. What is the stage of disease?
It will be stage 4, sir.
Okay, next.
Measurements, no limb length discrepancies for muscle. Movements are there is no restriction of active or passive movements, normal gait, no crepitus.
Okay.
Systemic examination, respiratory system air entry was normal bilaterally, CVS S1 S2 heard, abdomen was soft, non-tender, spine and
Which system do you think will be involved if you feel that this patient is having a sarcoma? Which is the main system of metastasis?
Pulmonary system, sir. Respiratory system.
Very good. So all sarcomas have a predilection. Most of the time they will go to the lungs and the hematogenous route, except the sarcomas you mentioned shortly ago, which has a lymphatic spread. Okay, so what is your final diagnosis, Aishwarya?
Sir, I mean, it is with history and examination. I would like to I would suspect a malignant bone tumor involving the right mid thigh, without involvement of the joint space, and history which was suspicious of lung metastasis.
Always, when you complete the examination, please say the other limb was normal. So that is another thing which I would like to always say. So always examine the normal side first.
Okay,
so you say this patient has the right limb swelling. I examined in the supine position. Left limb looks normal. The right limb on examination has. So then only it's like a case control. You have a control limb on the other side. So you compare with it and then say that one side is big and all that. Okay. So please always say that. Same thing with breast also.
Okay,
Even
sir.
in clinical practice, sometimes you examine the normal breast and go to the abnormal breast, you will find the small 1.5 centimeter lesion, otherwise you will miss it. Okay. So what you feel it's a malignant bone tumor without involvement of joint space, and did he have any cough or hemoptysis? Why are you suspecting lung metastasis?
He had dry cough of 1 month duration, sir.
So you are going to look for metastasis in your workup. So what next?
Sir, I would like to proceed with baseline.
We'll just leave it here. Don't. We need not run through the slides. So I'll ask you questions. You just give me the answer. What's your next with this?
Sir, I would start with the fitness evaluation, basic blood investigation, CBC with peripheral blood count, urea
All
creatinine.
normal. All
Then
normal. Next.
I would proceed with X-ray of right femur involving right hip joint and right knee joint.
Very good. So you have to involve both the joints while taking the X-ray. AP,
AP
PA,
and
lateral.
AP and lateral, sir.
You need AP and okay, very good. And do you have an X-ray?
Yes, sir.
Yes. Please read this X-ray image.
X-ray right femur, AP view. There is
Aishwarya, can you enlarge the? Can you go to your bottom screen and just enlarge that X-ray?
I'll try.
No, don't go down.
Okay.
Just go to the slide and select the slide and just pull it up. Yeah, correct. Other say other one. Yeah, here. Same. Just enlarge it. So just make the thing bigger. Yeah. Below you can come down and enlarge it. No, the screen itself can be enlarged. Yeah.
Yes, sir. 1 minute.
Actually,
It's
there is
okay.
just
It's
one
okay,
second.
just-
Another option is there where you can increase that 100% zoom to 150% or 200%. That
Yeah, exactly. Please. Yeah, that's fine. Please.
Sir, this is a X-ray of right femur in AP view. There is a lytic sclerotic lesion involving the diaphyseal region with a cortical destruction, and there is also a periosteal reaction with Codman's triangle and sunburst appearance, kind of periosteal reaction.
Codman's triangle, why is it caused? What is Codman's triangle?
It is because of the tumor infiltrating and lifting the periosteum, sir. And it forms a triangle with a normal bone surface.
What is sunburst? What is sunburst appearance? Why does it come?
It is a periosteal reaction, sir. It is because of
What's
the
the difference between Codman triangle and sunburst appearance then?
sunburst appearance also has a sclerotic component. So it's a lytic sclerotic component.
Why sunburst? How does it look? Codman triangle. Show me the Codman triangle.
So yeah,
That is very good. Do you have a sunburst or sunray appearance in this? Go to the next X-ray.
so this one.
What do you see there on the top part of the tumor? It's very less, but you can see it. Can you see some perpendicular calcification lines perpendicular to the bone surface?
Yes, sir.
So rays of calcification perpendicular plane to the thing is what is called sunburst appearance.
Yes, sir.
Not so big, just very small, starting from the periosteum and going up is called sunburst. Sometimes the examiner, with a very typical X-ray like this in the afternoon section, will ask you to mark the Codman triangle and sunray appearance or sunburst appearance. Okay.
Okay, sir.
I think even Raghu sir during 1 or 2 years back in the ASMPU had put up that, and then he's this is how it look and all that. So please, it's very favorite question. Fine. So at the end of this, are you able to come to some conclusion? What?
Yes, sir. Because of the sunburst appearance and this sclerotic lytic lesion, it's keeping with osteosarcoma, sir.
Bone tumor.
Bone tumor.
It's in line with a bone tumor.
Bone tumor, yes, sir.
So is this the right position for osteosarcoma?
Sir, no, sir. It is usually in the metaphyseal region, but around 10% can have in the diaphyseal.
Then why are you telling the 10% diagnosis after radiological diagnosis?
Because of the characteristic osteoid kind of.
I agree with you, but I think the safer thing will be this is likely to be a bone tumor. It could be malignant fibrous histiocytoma. It could be any high-grade sarcoma coming in the bone. This is a 43-year-old patient. So the safest will be not to say all those things. Don't give the histological diagnosis. Okay?
Okay, sir.
What's the next test you want? Quickly.
I would like to
Uditya is trying to tell me only 5 minutes left for you. Fast.
MRI of the right thigh region involving both the right hip joint and the right knee joint, sir.
Please get the MRI films quickly.
Sir, MRI films were not there, sir.
Put up the report.
Yes, sir. It was an MRI shows.
Okay, I will just ask you. Let's not go into all this because we are lacking time. So, do you need a CT or you need an MRI or you need a CT and MRI together in a soft tissue sarcoma that is coming out of the bone?
MRI,
Bone sarcoma.
MRI and CT are complementary, sir.
What do you see with CT? What do you see with MRI?
Sir, MRI will help us tell about any marrow involvement, soft tissue
Very
joint
good.
space involvement, any skip metastasis, better delineation of the tumor,
And what most important you'll see in MRI?
any neurovascular.
Very good. What does the CT tell you?
Sir, CT will tell us relation of the tumor with the surrounding structures and also any skip metastasis, anything can be picked up, sir.
Very good. So that is, I observe you. If there is a skip metastasis, what's the stage of disease in bone sarcoma?
It will be localized only, sir, based on the size.
Sure. What is the stage of sarcoma in skip metastasis?
Intracompartmental, it will still be stage 1.
Okay, just go back. Fine. So now, what is your plan for this patient? Udipti, I will just take another 10 minutes and we'll wind up this case.
Sir, next I would like to proceed with biopsy, sir.
So already this patient has a biopsy scar. Why do you want one more biopsy?
I mean, sir, I would review the biopsy report, sir. Slide and block, sir.
So what was your biopsy report?
It shows bony tissue with osteoid formation and scattered tumor cells with increased NC ratio.
Yeah, no, what's the final diagnosis?
Sir, it's osteosarcoma, sir. Features favoring osteosarcoma of right.
Causes of osteosarcoma in this adult male.
Any childhood retinoblastoma, Page's disease, prior radiation exposure.
You have excluded all that history, right?
Yes, sir.
What else? Can bone infarct cause osteosarcoma?
Yes, sir.
So what are the causes of bone infarct which can cause osteosarcoma later? What hematological conditions can cause bone infarct? Patient complains of a lot of crisis
Sickle cell.
pain and bone pains. Which hematological?
Sickle cell disease. Sickle cell.
Very good. So these are, and there is even any chronic inflammatory process in the bone, like long time osteomyelitis can cause. Fine. So otherwise, this is very rare.
Yes,
Now
sir.
that it is there, now how do you want to stage this patient?
Sir, I would want to do a PET-CT whole body, sir.
I don't want to see the image. Just tell me what are the PET-CT findings?
Sir, it had bilateral lung metastasis, largest
Many metastasis.
bilateral multiple lung metastasis, largest.
Does that matter?
Yes, sir.
Why?
If it was a unilateral lung and up to 4 months, still curative metastectomy can be considered after neoadjuvant therapy. Sir, I'm not able to hear you, sir. Sorry, sir.
Three or less, one side of the lung.
One
These
side.
are the good prognostic factors even in metastatic osteosarcoma. So lung only metastasis with less than or equal to 3 metastatic nodules, right?
Yes, sir.
Okay. What regimen do you want to use for this patient?
Sir, I would like to go for a MAP regimen, sir.
So you're using MAP in your hospital.
Yes, sir.
What's the dose of methotrexate?
12 grams per meter square, adriamycin 75 mg per meter square, and cisplatin 120 mg per meter square, split and given as day 1 and day
75, you give us 25, 25, 25, is it?
37.5, so day 1, day 2.
Okay, so in 2 days you give.
Yes, sir.
Okay. What is the definition of high dose methotrexate?
Methotrexate more than 500 mg per meter square, sir.
Okay. So what are the precautions you take prior to starting methotrexate, high dose methotrexate?
Sir, we would check all his kidney functions.
All normal. What else? In the ward, what do you do? He is pushed into the ward now.
We'll get a good central line, sir. Peripheral.
Then what?
And then we'll start IV hydration with 5% dextrose and 100 to 150 milliequivalents of sodium bicarbonate at 125 to 150 ml per hour. And we would check his urine pH. We can start methotrexate only if it is more than 7, sir.
Okay. So how many hours do you give this?
At least minimum minimum 7 to 8 hours, sir. Pre-chemo.
Methotrexate in your institution for MAP, over how many hours are you giving?
4 hours, sir.
And when do you start leucovorin rescue?
Sorry, sir.
When do you start leucovorin rescue?
Sir, 24 hours after the start of methotrexate, sir.
Okay, what is your target? Do you check methotrexate level?
Yes, sir. After 24 hours after the start of methotrexate, we send off the serum for methotrexate levels and then start leucovorin.
What is your target
For
methotrexate level, and at what hour do you check it?
24, 48, and 72 hours. At 24 hours, we had target less than 20, and at 48 hours, less than 2, and at 72 hours, less than 0.2, sir.
Is that the one in MAP protocol? MAP? Or like as an institute protocol, you are following the same for everything? Even for ALL and other?
Institute protocol, yeah.
Anyway, fine. Less than 0.5, some institutes say 0.2, BFM says 0.1, 0.2. Okay, fine. So in case you have found that the patient has 1 at 72 hours, what are you going to do? Methotrexate level is 1.
Sir, we would increase the dose of leucovorin and also continue the alkalinization, sir.
Creatinine has become 1.8 now.
Sir, if increased leucovorin also, if it is not responding and if he's kind of becoming, if creatinine is elevated and if he's becoming anuric, we might consider dialysis, sir.
Dialysis. Any other drug that can be used for reversing methotrexate toxicity?
Glucarpidase can be used, sir.
What is glucarpidase?
It is a recombinant bacterial enzyme. It is used to inactivate the methotrexate into inactive metabolites. It is given
What's the color of methotrexate?
Sorry, sir.
What is the color of methotrexate?
Yellow, sir.
Okay. And can you give me, last question, can you give me cisplatin ineligibility criteria?
Sir, ECOG PS less than 0 or 1. Any sensory neural hearing loss grade 2 or more, and creat clearance of less than 60 ml per hour. Heart failure with decreased EF of 60 or.
Is it comes according to EF or something else?
NYHA grade 3 or less, sir. 3. So,
ECOG performance status, NYHA grade 3, sensory neural hearing loss grade 2. Okay?
yes, sir.
Right. So please learn how to write a cisplatin order.
Okay, sir.
90% of the times you will be asked to write the order in front of the examiner. I know that you all use printed orders, but you should know how to write the cisplatin order, what all is given. Okay?
Okay, sir.
Yeah. Good, Aishwarya, all the best. Udipya, we can go to the next case. I think Vinayak must have joined by now.
Thank you, sir.
Yes, sir. Vinay sir has joined. Dr. Anisha, can you please share your screen and start
Yes,
the.
sir. Yes, sir.
Yeah, once again, Dr. Anisha, I just would like to reiterate this is a short case.
Yes, sir.
So please don't go through. I would appreciate you not to go through the case from the slide. Please just
Yes,
give
sir.
us a 2 to 3 liner about your history, important positive negative history, and then directly go to your differential diagnosis. Yeah, don't see the slide.
Summary, sir.
Once again, we would like you not to see the slide. It's okay. You
Okay,
can
sir.
just tell us. Yeah.
Okay, sir. Good evening, sir. So, this is a case of a 41-year-old male who presented with history of right testicular swelling since 1.5 months, with gradual increase in size, not associated with pain. Negative history, just the main points I would like to focus on, sir, is that he has no family history and no history of no significant past history. Treatment history also, he has undergone with these complaints. He was seen by a doctor for which he underwent a surgery where the right testis was and the tumor was removed. And then he was referred to us, sir. So with this history of a 41-year-old male with a painless, gradually increasing right testicular swelling since 1.5 months, I would like to keep a differential of a malignant testicular tumor, sir.
I was not able to
Anisha.
understand. Sorry, when I'll just confirm
Sir.
this history and then continue. Go. So this patient
Sir.
had already a right testicular swelling which was removed, and
Yes,
then
sir.
now has come back with a recurrent
No, sir.
right scrotum.
The history was that since 1.5 months he had a swelling, sir. He'd undergone an orchiectomy and then was referred
So
to us,
right
sir.
now you're presenting a case of an empty scrotum.
Yes, sir.
Okay, Vinay, please.
So why do you say testicular tumor?
Sir, gradually increasing in size, not
No.
associated.
No. Why is scrotal swelling? It is not. Why is the testicular tumor? When you examine a patient,
Yes, sir.
you'll only want to see the scrotal swelling. You don't know
Total
whether it is
swelling.
appendicular or
Yes,
testicular,
sir.
right?
Yes, sir.
So I have
Yes,
to
sir.
be very careful with those words. Okay, that's one thing.
Yes, sir. Yes, sir.
Say, go ahead.
Sir, should I go to examination, sir?
Yeah, okay. Just tell summarize what are the major findings.
Yes, sir. So examination-wise, the positive findings was that on general examination, a left supraclavicular lymph node, 1 into 1 centimeter, firm in consistency was found, sir. And local examination, there was a scar with an empty right hemiscrotum, sir, with a normal left side, normal left hemiscrotum, sir. No inguinal lymph nodes were there, sir. Other systemic examination was also normal, sir.
Okay. So anyway, there's not much of exhibition finding.
Yes, sir.
You conclude other systemic examination, please.
Sir, systemic examination, other systems was normal, sir. Per abdomen, there was no mass felt, no organomegaly. CVS and RS were also normal. CNS also, no gross neurological deficit was seen, sir.
Fine, good. So what do you think it is now?
So this age group with this history of an orchidectomy with the left supraclavicular lymph node, I would like to keep a Germcell tumor as my diagnosis, my differential diagnosis.
If his age was more than 50 years, what do you think a differential diagnosis would have been?
I would like to keep lymphoma also as a differential.
So what is the difference presentation-wise clinically lymphoma versus a germ cell tumor?
So lymphomas will be an older age group. There will be symptoms of B symptoms may also be associated of fever, weight loss, and loss of appetite, sir. And there might be associated other lymph node swellings also in case of a lymphoma, sir.
Okay. So coming to, let's go with germ cell tumor only. So how do you investigate? Let's assume that there's a testis. The swelling was around 6 to 8 centimeter, and they have come to you. So with that in mind, you just plan the treatment.
Yes, sir. So investigations, I'd like to divide into those which will help me confirm the diagnosis, investigations to help me stage and to see fitness, sir. For confirming the diagnosis, I would like to get an ultrasound of the testis, sir.
Okay.
On the ultrasound, I would look for any hypoechoic lesion to help me look for the testicular tumor.
Mhm.
And also additional vascularity I would look for.
Okay.
Other investigations, I would ask for tumor markers, sir. LDH, beta HCG, and alpha fetoprotein.
Okay.
This would help me get to the diagnosis of germ cell tumor, sir. For staging, I would like to do a CT abdomen and pelvis, sir. If I
Okay.
find something on that, then I would like to include even a CT of the chest.
Okay. So do you have all those reports,
Yes,
or
sir.
we?
I have that, sir.
Okay, fine.
So
Can you
yes, sir. Sounds.
can you confirm me what kind of marker level it is?
Sir, I have only the pre-operative tumor marker, sir. I don't. He, he didn't come back to us post-surgery with a post-operative tumor marker, sir. Pre-op I have, sir. Beta HCG is 1,300, alpha fetoprotein of 22,000, and LDH of 600. The ultrasound showed a solid soft tissue mass of 15 to 34 mm in the lower part of the right testis. with color Doppler showing vascular channels, and the left testis was normal. The CCT abdomen showed a large conglomerated nodal mass in the aortocaval, paracaval, and para-aortic region, causing right HUN also, sir. This was measuring 8 into 4 into 13 centimeters. There was a pleural nodule also that was there, which was 11 mm, and a left supraclavicular lymph node of 12 mm, sir.
So, what is the half-life of beta HCG?
Beta HCG is 24 to 36 hours, sir. Now it's
What is half-life of AFP?
5 to 7 days, sir.
Is a LDH a very specific marker for germ cell tumor?
No, sir. It's a marker of cell proliferation, sir.
Why it is a marker of cell proliferation?
I'm
Why
not sure.
it is? So, what is the pathway which is activated and this causes LDH to be elevated? What is LDH full form?
Lactate dehydrogenase, sir.
So, where is lactate dehydrogenase
In
enzyme
the
is utilized?
Krebs cycle, sir. Glucose metabolism.
Very good. So, when you do Krebs cycle, do you use LDH, or when you don't use Krebs
The
cycle, you use LDH?
anaerobic part of the Warburg, sir, where they use anaerobic glycolysis.
It's a Warburg phenomena. When there is a
Yeah.
urgent need for ATP, it will not go by Krebs cycle. So that is a
Krebs
marker
cycle.
of, okay. Is
Yes.
the tumor marker, one value is high is significant, or what is reflective of utility of a tumor marker?
No,
Like
sir.
example, I'll
As
give
in
example
only
now.
yes, sir. Yes, sir.
I'll give 1 cycles of chemotherapy. The tumor marker actually increases. So what is your indication that? I give 1 cycle of BEP. The tumor marker, which is around 1300, shoots to around 2000 units. What do you think it is? Not responding to chemotherapy or what?
No, sir. I would continue the regimen. I mean,
So what is this phenomena called actually? Okay, fine. Let's not answer that. Okay.
Responding patient with increasing markers or findings. What will you call it, Dr. Anisha?
flare, sir. I'm not sure, sir.
So usually there's a cell death and there will be lysis of the marker into the thing. So anyway, so with this kind of finding, so we have talking about right testis, right?
Yes, sir.
So what is the landing zone? Do you know what is landing zone?
Yes, sir. For the right testis, it's a paracaval node, sir, and the left testis, it's the interaortocaval, sir.
So which one crosses midline? Which one doesn't cross midline? Which one crosses midline?
Interaortocaval, sir, will cross the midline, sir.
Okay. So by looking at this picture,
Yes, sir.
what would a biopsy would have been sufficient if you done a CT guided biopsy from the abdomen instead of doing orchiectomy? Is it okay, acceptable?
No, sir. I would still ask for. I mean, for the exact T staging, we would require an orchiectomy, and
For diagnosis, would be sufficient with CT guided biopsy, or you really need to do orchiectomy?
orchiectomy should be done, sir.
So what kind of this is called orchiectomy done? What is the typical surgery is called?
A high inguinal orchiectomy, sir.
What is high in it? In what
We,
relation it is high?
as in the scrotum, we don't. The incision is made above the inguinal ligament, sir. That is the high inguinal, and the scrotal skin is not compromised because there is a risk of inguinal lymph node metastasis in upstaging.
Okay. So fine. Then let's go for the with this information. Can you stage the patient?
No, sir. I don't have the post-operative tumor markers are not available, sir.
Let's assume it is
Do you need a post-operative tumor histopathology to stage this lesion, Dr. Nisha? What is your CT showing and what did you clinically
Yes,
pick
sir.
up in this patient?
Node will be N3, sir.
That
T
is
stage
rare. Okay, so is it stage
and
1, 2, or 3?
3, sir, because I have a left supraclavicular lymph node.
Yeah, so Professor Vinayak is asking you that.
Sir,
So
but
why do you need a surgical specimen to stage this patient?
no, sir, tumor marker, sir.
Still
Okay.
S is X, no. Still is see what
Yes,
happens
sir.
if I give S for same diagnosis now,
Yes,
I'll
sir.
give S1,
Yes, sir.
S2, and S3. You tell me what it stage it happens.
Sir, between it will still be stage 3, sir. Between A, B, and C, it would help in that, sir.
So only S3 will change your status,
Two.
right?
Yes, sir.
Not otherwise, right?
No, sir.
Okay, that's why I'm asking because most of the what is the diagnostic staging called?
IGCCC, sir.
Then what is risk stratification called?
IGCCC.
IGCCCG. International Germcell Cancer Collaborative Group, sir. It's a risk stratification, sir.
Yeah, it is not the staging. Staging is still your TNM staging only.
Yes, sir.
Okay. So what is the importance of that risk scoring system?
Um, for it will help us in one prognostication and between good and intermediate and poor, the number of cycles of BP versus BP and will be we'll be able to decide on the number of cycles of BP, sir.
No, that is treatment or it is it what is it full form? You tell me one second.
International Germ Cell Cancer Collaborative Group, sir.
Prognostic group, no?
Yes, sir.
So what is the prognosis here now? Like if assuming it is good and intermediate and poor.
Yes, sir.
So what is the this is a risk model actually.
Yes,
So
sir.
what is
They
survival
give
expected in good risk?
for seminoma, sir. 5 year for good risk, 5 year OS was about 95%, sir. In intermediate risk, 5 year OS was 89%, sir. In metastatic non-seminoma, good risk was 95, sir. Intermediate was 89, sir.
You keep it
And
very simple.
OS
Keep it very simple.
some
Just Anisha,
85, something like that, sir.
no, keep it simple. First, finish off seminomas.
Yes, sir.
Then see. So, do you think it is for low risk also? Low. To what stages you apply this one?
Advanced
It
stage, sir.
is advanced stage, no?
Yes, sir.
So, for you have to tell the stage and tell the prognosis. Okay.
Yes, sir.
Why do you think there is no poor risk seminoma is there?
Mm. So because of the very good prognosis, sir, there is no poor risk at all.
Okay. So what makes poor risk in non-seminoma? Three risk factors.
Yes, sir. Mediastinal primary, non-pulmonary visceral metastasis, and S3 tumor markers, sir.
Is a bone met non-primary visceral met or not?
Yes, sir.
Is it bone? Why? It's not visceral, no?
Yes, sir. Sorry. Yes, sir. Yes, sir. Sorry. Yes, sir.
So again, I'll ask you: does bone met indicates poor prognosis or not?
No,
So
sir.
actually,
Vis-
it is not. It is not a visceral mets thing. It is a pulmonary visceral mets. Plural mets are counted as a non-pulmonary visceral mets. Bone mets
okay, sir.
also are counted as non-pulmonary visceral mets. Okay.
Yes, sir.
It's only okay. It's a exclusion thing. Anyway, so this patient you have a stage 3 and surgery is done. Post-op markers still show S2 markers. So what your stage will be? Final stage.
Stage 3, 3B, sir.
Okay. In this risk, now what is your plan? Now, as you said, do you have all the investigations?
Yes. Oh, sorry. I have
So
the.
so these are the stage to confirm the diagnosis. These two
Yes, sir.
investigations are confirm the diagnosis.
Yes, sir.
Second, for management and extent of the disease.
Yes, sir. Baseline investigations were all normal, sir. CBC, creatinine, LFT,
So
they're all normal, sir.
what is the importance of hemoglobin or PCV in the evaluation of mixed germ cell tumor or germ cell tumor? What is the importance of it? If hemoglobin low and patient is breathlessness, what it indicates? Anything you think of? In patient with the low hemoglobin, with breathlessness, with poor GC and
Bleeding from
headache.
some sites, sir. Choriocarcinoma syndrome.
Mm. So there is a in choriocarcinoma with the liver with lung mets, they are predisposed to have brain mets. So what? How do you test this one? What?
I mean, for choriocarcinoma, sir.
No, the involvement of brain in choriocarcinoma.
MRI brain, I would like to get done, sir.
If MRI is normal,
I'm not sure, sir.
so if the complaints headache fundus is showing papillary
PSF,
edema, yeah. So what do
lumbar
you do with
puncture,
CSF? So you think it is leptomeningeal disease or what it will see? In when you do the testing for CSF, what you will test?
cytology, sir.
Cytology
Then
from neck.
Or
cytology or
any
something else. He's giving you a clue.
So tumor marker is there also there. Okay.
okay,
The
sir.
ratio of CSF tumor marker to the blood marker is indicates the involvement of CNS involvement in. And only one question before we go to other thing. How do you treat this kind of patients who have brain mets, patient PS is low, and what is the treatment option there?
We wouldn't start sir with a full regimen of BEP. Ideally, we would give a shorter course of EP of just 2 to 3 days of at a lower dose.
What is the ideal
As a
regime which is
first,
been, what is
as
the
a
ideal
first
regime
dose
which
of,
is just 1 minute, Anisha.
sorry, sir.
What is the ideal regime which is tested in this kind of condition when the PS is low and patient is upfront cannot be given full dose of PEP?
I know.
Hear the word baby Bob's protocol?
Yes, sir, baby. Yes.
That is the patients where you use it. One
Yeah.
question is what to do with brain thing? Do you want to give radiation or not? Question is that.
If
If so,
patient
when?
is acutely symptomatic, I would say, but they are chemo responsive, so I would prefer to go with systemic therapy.
Okay. So usually sometimes they advise radiation because the full dose chemotherapy cannot be given. But as you said, there's some baby pop-up single agent carboplatin also been studied where they get them to put PS. So if patient was not operated and upfront presented with poor PS, what would you do in such patients? Would you go and do your orchidectomy?
No, sir. If patient is symptomatic and we have elevated tumor markers, then we can start off with the treatment
Without
without
diagnosis, without
without
the
the
biopsy?
tissue diagnosis. Yes, sir.
Sure. You have such a big lump sitting the abdomen mass. Why don't you do CT cut biopsy?
If the patient cannot tolerate its poor performance status and compressive symptoms, then I would, with the tumor markers, we can start treatment, sir.
So, I mean, that my ideal circumstances, we may start small dose, but we want to get a tissue diagnosis, especially when we don't know the primary, especially when the primary is burnt or something. Okay. So, if you do start chemotherapy based on either biopsy or tumor marker, when is ideal time you want to do orchidectomy? At the completion of all 4 cycles or after 2 cycles?
After all 4 cycles, sir.
Why? What is a blood testis barrier?
That is, yes, sir. Uh, I mean, because of the blood test barrier, we still have to do, even in spite of the chemotherapy, we would still have to remove the testicular tumor, sir.
So what happens is all the chemotherapy you give will not reach the testicular
Testis.
the space in a adequate quantity. It too reaches, not in adequate quantity. The rationale is every time you remove testis and you find a viable tissue, you have to give 2 cycles. Either it is after 4 cycles or 2 cycles. So if you find a viable tumor in testis after the surgery, you have to give 2 more cycles. So ideally, people prefer after 2 cycles, sparing. When does the etoposide toxicity increases? From what cycle to what cycle? At
After the
what dose the
second cycle, sir.
sure?
Like
What is the dose? It's the can you give me
100
the
mg.
dose? No, no. Can you
Sorry,
give
sir.
me the etoposide dose and its incidence of leukemia? Anyone, any students can post it in the group. Actually, it is for everyone. So it is usually between the fourth and fifth cycle that the risk increases, exponential risk increases. So we need to be careful with that part. Okay. Do you have
Yes, sir.
any other investigation to show, or we can go at the questioning only?
So the histopathology of the orchidectomy.
It's done. You should know.
Yes, sir. That's all.
Okay, only one question now I have is what is the chances of teratoma incidence in node?
The percentage, I'm not sure, sir. I
So
don't.
you have teratoma 80% in the primary.
Yes, sir.
What will be the percentage of teratoma in the nodes? It's
It
mixed
could,
stem cell tumor, no?
yes, sir. It could be teratoma, it could be embryonal, sir.
Okay, okay. There is a if you have zero teratoma in the primary in the orchidectomy sample, the chances of still teratoma being there in the mixed or non-seminomatous, it is still 30%. But if it is already
Yes, sir.
there, definitely even the what are the problems of teratoma during therapy?
Growing teratoma syndrome, sir, because of the chemo-resistant nature,
Mm.
they tend to grow and invade into the structures, causing symptoms, sir.
So we'll go after the this one. Let's assume now this case. Now what you wanna do next?
Um, post-operative tumor markers I would like to get, sir. For
It is. I told you last time only. No, it is shrink by
yeah,
1 log. That's all.
okay, sir. And then I would like to, as all the baseline investigations are okay, sir,
Done.
I would
All are
like
normal.
to,
All are normal. 2D echo is normal,
yes, sir.
and patient
Yes,
has not married interestingly. But what do
y-
you want to do?
yes, sir. That's it. So I'd like to counsel regarding semen analysis and sperm cryopreservation, sir.
Okay. So is there any fertility issues in the patients whom you are offering sperm banking or what the thing? Is there any issues with germ cell tumor? Do they
It,
interfere with fertility thing?
so germ cell tumor patients can present with infertility at presentation itself.
Mhm.
Uh,
Which are the
so
syndromes known to occur with germ cell tumor?
Klinefelter syndrome, sir. They
What
also
kind
have
of what kind of histology it will be there?
um, histology, sir.
Yeah, yeah, which histology? Any trend?
Mediastinal, they're usually mediastinal germ cell tumors, sir.
Really? So, what kind of hematological disorders they'll have when they have medicinal
Uh,
this
yes, sir. AML M7, sir.
M7 is? Okay, fine.
Sorry, sir.
Let's go. No, 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 no. Questions I'm asking, you can read it and again
Yes, sir.
answer it. So this patient has taken. You've done all the workup. You've done PFT. You've done 2D echo. You've done even EGFR, the GFR testing and everything. Anything else you want to do other than that? Toxicity, baseline toxicity profile analysis.
No, no, sir. I mean, after counseling for the sperm cryopreservation, then we can start off with treatment, sir.
Mm. Okay, so what is the drug you use in the this treatment?
Bleomycin, etoposide, and cisplatin, sir.
Okay, so which is the backbone of this treatment?
Cisplatin, sir.
If I remove cisplatinum and add cyclophosphamide, so how much the cure rates will fall?
I'm not sure, sir. I don't know.
So how many cycles you want for this patient? It's a intermediate risk or good risk?
So this would be um,
I told S2.
S2, sir.
Mm.
Then intermediate, sir. I would like to give 4 cycles of BEPs.
BP.
Yes, sir.
What does guideline
BIP.
says?
Four
So how
cycles of
many?
BEP or
Be
BIP,
clear.
sir.
Be clear. Be clear. It's very important. Be clear. Do
Yes,
you
sir.
want to do 4 cycles of EP or 3 cycles of BEP, or you want to do 4 cycles of BEP?
The intermediate and poor risk, I would like to give 4 cycles of BP, sir.
Okay, fine. So what are the toxicity of bleomycin?
Pulmonary toxicity, sir. Uh,
Okay.
Skin rash also, sir.
Okay. What is the rash characteristically called?
Flagellate rash, sir.
Okay. So once you do this chemotherapy, after 4 cycle, patient who goes in remission, what you'll
Yes.
do now? Remission means how will document the remission?
Um, Tumor marker, sir, and imaging.
Tumor marker is almost normal now. What do you want to do next?
CT of the abdomen, sir. Abdomen pelvis.
So in the abdomen, you find a mass of 8 centimeter. What you will do next?
Nerve sparing RPLND, sir.
Why you will do nerve sparing RPND? What are the guidelines to tell to do surgery?
Yes.
Whom you will offer nerve sparing and whom will not offer nerve sparing?
Sir, as there is a residual mass of more than 1 centimeter, we should
1 centimeter is criteria. What is the criteria cutoff?
For
Where you will observe.
non-seminomatous, it is more than 1 centimeter, sir. Seminoma is 3 centimeters.
Okay. So in seminoma, do you operate or radiate?
No, sir. In seminoma, if there's a residual tumor of more than 3, after 4 weeks, we do a PET CT and look for avidity. If it is avid, then a surgical resection, if possible, should be done, and we look for viable tissue or fibrosis.
So in this patient, why you're not doing PET scan? Because there is a 20% seminoma involvement. Why you're not doing PET scan for this patient?
I would.
Anyway, no issue. So it will better to do PET scan so that you
Okay,
know there
sir.
is no seminoma element. Unlikely
Okay, sir.
seminoma will persist after the 4 cycles of BEP. But
Yes, sir.
teratoma would be element which has to be addressed. And if it is more than 5 centimeter, it will be radical surgery. Unlikely it will be a
No
nerve sparing
sparing.
surgery. Okay. So
So,
nerve
so
sparing
if
is.
this 20%
Yeah.
seminoma is there, sir, we should along the residual that algorithm as seminoma, sir, or
No,
non-seminoma?
not seminoma.
Because it's a mixed GCT, so we should go as
The only
non-seminomatous, sir.
Yeah, only problem with this teratoma elements no, will stay back after the chemotherapy also.
Yes, sir.
By default, surgery will be the option for them. Observation is unlikely.
Yes, sir.
Sometimes if the shrinkage is more than 5 centimeter, we tend to observe because especially he's on 41-year-old and he's not married. Not only the fertility issues, there will be potency issues.
Yes,
So
sir.
you would want to do active surveillance for them.
Yes, sir.
And teratoma usually will not go with chemotherapy. It will be there.
Has to
So
be.
we'll address it later date. If it is growing only, we'll address it up.
Yes, sir.
So this is, I think we are falling on short on time.
Yes, sir.
In this patient, if he relapses, what are the salvage regimes?
Vinblastine, ifosfamide platinum.
Which is the best salvage regime for germ cell tumor, relapsed germ cell tumor? Best regime in terms of cure rates.
TICE regimens.
What is TICE regime?
Taxane, ifosfamide, carboplatin, and etoposide, sir.
You sure?
Yes, sir. High dose chemo followed by auto transplant, sir.
So usually salvage
Survival
regime
rates
is
were highest, sir.
no. Yeah, there are two options here. One option is you want to do high dose chemotherapy, and
Yes, sir.
second option is salvage regimes also. Sometimes you don't have to do a high dose chemotherapy for every patient. There are two schools of thought. What is the index which is used to stratify the germ cell tumor whether they should go for transplant or not? Is there in the
Yes,
in
sir.
the
It's there in Devita, sir.
What is
Not
the criteria?
Bayer's
Criteria?
Bayer's score, sir. Yes, sir.
Okay. Anyway,
Yes,
that's
sir.
there. So that criteria is used, but usually tip has a highest salvageable regime. There is mini tip, but amount of cure rates which you get the tip is highest with the cure rates. For them, patients you can do surgery and get away without doing transplant. Which are the patients who are biologically very resistant to treatment? This is the last question.
Where the tumor markers don't fall, sir, in those I would think are refractory.
Mediastinal, primary mediastinal non-seminal germ cell tumor are the worst prognosis. Usually, they are very chemorefractory. For them, there are a lot of there's a definition called cisplatinum refractory germ cell tumor. In that subset of patients, what are the drugs which have been worked in that patient? In germ cell tumor, is there any role of any newer drugs?
I'm not sure, sir. I heard no, sir.
Immunoglobulins,
Immunotherapy I heard, sir, but I'm not sure.
That's okay, not relevant. If you go there, it's difficult. Anyway, this is good presentation. So the thing which we will most of us will struggle is the how to handle retroperitoneal node. Okay,
Yes, sir.
node is the most difficult one in our understanding because we refer but we don't address. Just to summarize for all students to remember, you have to divide in seminoma. Okay, in seminoma, they can be in early stages. You can do a prophylactic radiation to the para-aortic node only as an option. Okay, in the early stages. In later stages, size matters and PET avidity matters. Only lesions which are PET avid and more than 3 centimeter, they will undergo either radiation or surgery. Whereas in non-seminal tumor, the prophylactic surgery is done for patients who are high risk of relapse, especially LVI positivity is there in the primary sample. They will go ahead with a nerve sparing RPND. This is called as prophylactic RPND, which is always a nerve sparing. Whereas advanced disease like what we have, is already all nodes are involved. We would go for radical surgery whenever it is indicated. Yeah, someone has asked what is salvage and desperate. Do we have time, Udip?
Yes, sir. We can take another 2 minutes.
Yeah. So usually what happens is the salvage options are planned ones usually. Just I told earlier, when we start treating patients with germ cell tumor, they are more than 5 centimeter. We have to take a tumor markers are rising or something. It has to do. But when you do it in growing tumor markers, it's kind of desperate, and sometimes we don't know it's a growing teratoma or it is a growth that's done. It's unplanned and it becomes very now no one does RPND. The way you separate RPND is nerve sparing, plated the
Yeah.
the plated one and radical one, modified radical one. So there are three variants of RPND are there. I don't know. CART is planned everywhere, but I don't know what antigen. I mean, someone can post it out. Uh, the this especially seminoma are very immunogenic, so they will respond. The response rates to the checkpoint inhibitors have been very dramatic and better. So Ratnam sir only have to tell. He's only asked the question. Any
So,
concluding
Udipti, I just
remarks?
want to wind up with few questions if Vinayak will permit. So, I think this is a very typical prototype case which has been put up by the candidate. Okay. So,
Yes.
Dr. Anisha, you did well,
Yes, sir.
but please be very careful with whatever you're saying. First of all, when an examiner asks you, is orchidectomy needed? Yes, orchidectomy is definitely needed, even when there is disease outside of the testis, because there is a blood testis barrier, so it has to be removed. So that
Yes,
should
sir.
be your answer, not purely for staging. Orchidectomy for staging is very important only if it is stage 1, because you want to know which patient will you and why high in high inguinal orchidectomy, then only you will get the exact staging and whether there's a spermatic cord involvement and other things. You will have to say that.
Yes,
And
sir.
the second point is, as what Dr. Vinayak was asking you, you should be very clear as to S1, S2, S3 as low, intermediate, and high risk has a change in the stage 3. Okay, not otherwise. Others, it is all mostly related to the TNM only. The poor risk and intermediate and high risk comes based on the S1, S2, S3. So you should be able to confidently tell it is a 3B intermediate risk. And please be clear what is salvage chemo and what is given for high dose. Vinayak asked you if this patient is relapsing, what you will give. So you
Yes,
have
sir.
to go to VEIP, you have to go to TIP or VIP, one of those regimens, and what you give in transplant is high dose chemo.
Yes, sir.
So don't directly tell about what chemo you give in transplant when they ask what is the salvage regimen. So
Okay, sir.
that you should know. And point number 4, which I noted what you said, was when there is a brain involvement, once again, because of blood-brain barrier, your chemo is not going to reach the brain. That is one risk. Second thing, when it's a choreo component, that is the one which mostly goes to brain. They are executively sensitive to chemotherapy, so even little bit chemo goes up, the choreo will melt like anything. And when you have a slightly larger brain metastasis, it may immediately bleed.
Bleed.
Okay, so in these cases, many times radiotherapy is given upfront to prevent that bleed, and then a low dose chemo like BEP3 or whatever Vinayak was mentioning. In some centers, they use the lower dose of BOP and all that. You give that and then stabilize the patient, and then you go for that. Should be the answer. So when there is a brain involvement, you should know what to do. Similarly, when patient comes with very high beta HCG value, they may have even tumor lysis. These are the rare cases where you even have tumor lysis in solid tumors, and patients will land up in trouble when you start full dose of chemotherapy. That you should be able to say. And no nerve sparing RPLND in the salvage setting. When you're going to salvage a retroperitoneum node which is left behind after chemotherapy, it is always a radical RPLND. So don't talk about templates when you're talking. It's only for the initial staging in stage 1 and select stage 2. Okay. And the other thing which I wanted to tell you was, when there is a teratoma of 80% in the initial specimen, your exam answer should be the 1 centimeter criteria doesn't hold. When you have such an extensive teratomatous element, even if there is a 0.5 centimeter residue, if it is resectable, we have to go in and resect, because if you leave the teratoma behind, you'll have a growing teratoma syndrome. Most commonly asked question by the examiner. And once again, you'll have to be, Vinayak nicely explained for those who don't know what is desperation surgery versus salvage surgery. Salvage surgery is whatever is left behind, you're going and salvaging. That is salvage surgery. But desperation is, you tried everything. You tried first line, you tried second line. Maybe you tried a high dose chemo and transplant also. Again, there is a slow rising. Usually the marker will be AFP. And if you have an isolated disease only in the retroperitoneum and nowhere else, that is the best subset where you go and desperately remove whatever is left behind, hoping that the tumor marker will go away. That is what is called desperation. You are desperate searching. Now you have a patient progressing with tumor markers all over the place. He has multiple lung mass, brain, and has even bone metastasis. You're not going to go and do desperation surgery in those cases. So don't say that at the end of chemo, if still the patient is progressing. I've heard this answer from some candidates. If patient is progressing after 2 or 3 lines of chemo, or we go and do surgical salvage, it's called desperation. No, only if there is a solitary site, mostly in the retroperitoneum, 1 marker elevated, and mostly it is S1 marker, then you try to go desperately remove that and see if the patient responds to it and then gets cured. So that is the answer for desperation surgery. Of course, who should go for transplant and who should not go for transplant, you should very clearly know about that. Okay, and then how to manage etoposide reaction and anaphylaxis in the ward. All testicular tumor patients, whenever you're talking about etoposide, this question will be asked. You should know how to manage etoposide anaphylaxis. Please go and read about that also. Okay.
Yes, sir.
Thank you. Yeah, and thank you.
Sir.
I would request Dr. Anisha to stop sharing. And Dr. Sriram, you are please put in your presentation and start the case presentation.
Good evening, sir.
Sriram, can you, like what Anisha did, can you please summarize your case in 2 lines?
Yes, sir. This is a case of a 67-year-old male who's a chronic alcoholic who presented to us with abdominal pain for the past 2 months, yellowish discoloration of the eyes, and passing of yellowish urine for the past 1 month, and abdominal distension for the past 1 month. He has actually he's a chronic diabetic and also has like history of undergoing a endoscopic procedure recently, and also a stent insertion has been done, following which a biopsy has been taken. He later presented to us for further evaluations.
So with just this history, what is your suspicion?
Sir, so patient typically gives history of obstructive jaundice. So my impression is like, first I would like to place a differential of any malignancy of the hepatopancreaticobiliary system, followed by second differential will be a liver mets, sir, from any side.
Now that the stent has been placed, you very clearly told that stent was placed. Patient is educated enough to say that.
Yes, sir.
So probably your first one holds good. Your clinical examination.
So general examination, sir, is of ECOG performance status 2. There is icterus and pedal edema. There is actually no other positive findings. Vitals are all stable. Inspection of the abdomen, there is the abdominal distension is present and umbilicus is everted. There is all quadrants move equally with respiration. Flanks are full, hernia orifices are free, and there are no scar sinuses or dilated veins. On palpation, like I could appreciate a few small nodules in the abdominal wall in the right lumbar region. And percussion, there is shifting dullness present. And liver span is normal. Auscultation, bowel sounds are normal. There's no abnormal bruit heard. And I did a per rectal examination and as well as examination of the external genitalia. Both are normal. Other systems are also normal.
In general examination,
Yes, sir.
what is one thing you want to rule out in such patients?
Cachexia and signs of liver failure.
So what are the signs of liver failure you examined?
So I look for alopecia. I look for parotid enlargement. I look for gynecomastia, palmar erythema, look for Dupuytren's contracture, testicular atrophy.
So now once again, when you have a case of obstructive jaundice, let us say this is from the either the pancreas or from the so do you expect all these typical signs of liver failure what you told me now?
Usually, sir, like HCC patients like commonly have liver failure. Not all patients it will be positive.
So only in patients who had long-standing cirrhosis turning into HCC, you may find all these things. Otherwise, typically you're not going to find except acute liver failure or a fulminant hepatic failure, which may come in towards the end of the disease course in all patients with liver metastasis. Okay.
Yes.
What else in the abdomen examination? Are there some clinching diagnosis? You find something in the abdomen. Let us say this, leave your patient. If you have a patient, you're examining a patient.
Yes, sir.
I found this in the abdomen, so I feel this may be the probable origin of tumor. Do you have some clinching diagnostic signs in such a
Palpable
case?
gallbladder.
So what about palpable gallbladder? You're right.
If it is a palpable gallbladder, it is like Courvoisier's law says it is not due to stone. It may be enlarged in like carcinoma of the gallbladder or sometimes in periampullary tumors.
You are right, partly right. The one more feature to that, painful or painless?
Painful.
Which will be painful?
Stones will be painful.
So you just add that one word, a painless palpable gallbladder, if found in a case of obstructive jaundice, is likely to be due to malignancy of the head of pancreas and very unlikely to be due to cholecystitis, right?
Yes. Yes.
So Courvoisier's law or Courvoisier's sign, right?
Yes, sir.
Good. So did you find any palpable gallbladder in your
So
patient?
no, as such clinically I couldn't find, sir. He had ascites, even on deep palpation I couldn't find.
So now what is your, so you have a metastatic malignancy with obstructive jaundice.
Yes, sir.
So epidemiologically, patient is coming from Kannur. So what do you think would be the possible primary? In Kerala registry,
Yes, sir.
please tell me the top 5 cancers.
Sir, especially in Kerala, sir, in hepatobiliary, pancreas and cholangio have a predilection, sir.
Why?
Sir, one is like he's also a chronic alcoholic. Could be there, and some like I'm not aware of any specific.
Is there any food association with pancreatic cancer?
High fat.
Food intake in Kerala, which is on the higher side, can cause pancreatic cancer.
High fat diets, red meat and high fat.
No. Any other vegetable or any part of a fruit, I mean, of a vegetable which is consumed in high numbers that can predispose a patient for both pancreatic cancer as well as calcific pancreatitis?
Not aware.
So your friends are trying to prompt you, no? Tapioca. Okay?
Yes.
Fine. What is the cause for cholangiocarcinoma? How do you classify cholangiocarcinoma? And what's the important history that you have to take for in each of these cases?
Yes, sir. Cholangiocarcinoma can be, sir, intrahepatic, periductal, and distal, mainly. And
what is the cause of intrahepatic cholangiocarcinoma? What is the cause of extrahepatic cholangiocarcinoma?
Sir, mainly like in intrahepatic cholangiocarcinomas, there can be like infections like HIV, clonorchis, opisthorchis. Then the hepatitis B carriers can also have increased risk. For
Chronic liver disease predisposes to intrahepatic cholangiocarcinoma. What are the causes of extrahepatic cholangiocarcinoma?
extrahepatic can be some like sir, presence of some exposure to some environmental like polyaromatic hydrocarbons.
And what's the most common cause of pancreatic cancer or gallbladder cancer?
Stones.
Most commonly, it is due to gallstones. So now why I'm asking you this question is, epidemiologically, is there any difference in India, Asia, and rest of the world when it comes to intrahepatic and extrahepatic cholangiocarcinoma? Which do you think is more common in India, or
Sir,
which is having a rising trend?
Sir, in India, actually, both in India, actually, sir, this distal cholangiocarcinomas are common.
Are you sure?
DB, sir, worldwide
All
most
over the
common
world,
is
generally
perihilar.
extrahepatic is more common.
No, sir, perihilar is the most common. In
Okay, that's what extrahepatic. So what about India and Asia compared to the rest of the world?
Sir, it's slowly rising trend is showing. Intrahepatic is showing a rising trend now.
That is because of the infective etiology. Generally, in developing countries, you have slightly higher risk of intrahepatic cholangiocarcinoma. So now, what investigation do you want for this patient?
Sir, like I would like to review the. I would like to do a CECT thorax, abdomen, and pelvis, sir.
Okay, so
they had already done an ultrasound from outside.
What was the ultrasound finding? You can just tell me. You don't need to put up everything on the
They
screen.
had initially done an ultrasound which showed a proximal body of pancreas being edematous. There was a hypoechoic area adjacent to the body of pancreas, and like there was liver was showing a coarse ecotexture. And apart from that, there was only grade 1 fatty liver.
So where do you think is the primary node?
Sir, probably either in the pancreas or in the periampullary region.
Okay, so now what test do you want to do?
So next I would like to do a CECT of the thorax, abdomen, and pelvis.
Okay, I will give you the findings. Here you have a patient, case number 1. You have a patient who has, I will give you the findings. I will give you the various systems, so you don't need to put anything on the screen. So you have a patient who has a tumor which is present in the head of pancreas, which is encasing the mesenteric vessels by about 200 degrees on contrast, and then patient has few peripancreatic lymph nodes.
Yes, sir.
No other distance metastasis. This is one case scenario. It's not your case. It's a case scenario. What do you want to do for this patient?
Sir, first of all, I would like to discuss with my gastroenterologist and surgeon for a biopsy. Like
when the stent was put, a biopsy was done.
Biopsy was done.
Biopsy
was done, sir.
You can just review that, no?
Yes, sir.
Okay, biopsy has been reviewed. I will give you the findings, so you can leave that. So the biopsy was reported as moderately differentiated adenocarcinoma, periampullary region.
Yes, sir. Moderately differentiated. Okay, sir. Sir, actually, this is like there is 200 degrees of encasement of the SMV. That makes it actually, sir, a borderline resectable patient. So I would like to discuss with the surgical team if still surgery is.
It's the best neoadjuvant chemotherapy regimen that you can consider for a patient with periampullary tumor.
Sir, I will consider like either modified FOLFIRINOX regimen, whose if our surgery is on the cards, or you can also go ahead with the gemcitabine and nab-paclitaxel.
So how is nab-paclitaxel given?
Sir, nab-paclitaxel is available in a powdered form. In our institute, we usually mix it with 50 ml NS, and then in a sterile bag, it is given over 30 minutes.
Have you reconstituted nab-paclitaxel?
Yes, I have seen, sir. Personally, I have not done it myself.
What is the instruction you will give the sister when the nab-paclitaxel is being reconstituted?
Sir, it usually becomes crystalline deposit. It has to be mixed completely with in saline.
So what you should not do while mixing nab-paclitaxel?
You should not mix it very fastly, rapidly.
So while mixing the nab-paclitaxel with saline, you should do it with the bottle in an inclination, and the saline should be mixed along the side walls of the glass bottle. And then once you add 20 ml, you leave it. You cannot put 50 ml into a nab-paclitaxel bottle. It can't hold more than about 20 ml. So you put it inside the bottle slowly and allow the whole granules to disperse. And then you swirl the bottle and you don't shake it back and forth. The reason is because when you shake it back and forth, it becomes a curdy suspension, after which you can never take it out of the bottle and half the medicine will go and it will not mix in saline also. So a curdy precipitate should never come, and then your 9,000-10,000 rupees bottle goes waste. So you should only swirl it slowly. After some time, slowly the granules will disperse. Okay, so that should be the answer you give in the exam.
Yes.
Okay,
yes.
Fine. So you can give gem nab-paclitaxel or you can give paclitaxel. I agree. How is folfirinox given?
Sir, folfirinox, sir, is actually a first of all pre-medication, sir. It is we'll give injection dexamethasone 8 mg, injection ranitidine 50 mg, injection.
That's fine. So once you're given the antiemetic regimen, what are the
Yes,
doses
sir.
of folfirinox,
So
modified
first,
folfirinox?
sir, like irinotecan is given at 180 mg per meter squared in 500 ml NS over 90 minutes. Oxaliplatin is given at a dose of 85 mg per meter squared. It is given in 5% dextrose, 500 ml 5% dextrose over 2 hours. And along with that itself, injection leucovorin is given at 400 mg per meter squared in 500 ml 5% dextrose over 2 hours. Then in modified folfirinox, there is no bolus actually. So 5FU is given at 2400 mg per meter squared in over 44 hours.
You have given modified folfirinox. Actually, you have downtraded the dose even by another 15%. Patient comes back in 6 days.
Yes.
With severe diarrhea.
Yes.
With severe diarrhea and count is 100. What are your thought processes in the mind?
Sir, one could be like one is a neutropenic colitis, could be a possibility. DPD deficiency due to 5FU. Like
apparently, this patient has been worked up earlier in another center. Now the report comes to you. Patient has DPD wild type.
Sir, if patient again irinotecan can also cause diarrhea, sir.
What other blood investigation, when you see, you feel, could tell you that this patient has irinotecan toxicity?
Sir,
which patient is predisposed to get irinotecan toxicity? Like DPD, anything else in the patient?
UGT1A1.
So a patient who has UGT1A1, what is, even before starting chemotherapy, are there some blood parameters which can tell you that this patient has UGT1A1?
Sir, presence of like indirect hyperbilirubinemia and also marginally raised alkaline phosphatase.
So in which other syndromes can you find indirect hyperbilirubinemia, and this has a drug interaction and patient can have a lot of indirect hyperbilirubinemia going up? And can you give me the name of some other drugs, especially hematological malignancy use one, where
one is like
it is very
Gilbert
common
syndrome.
seen?
Okay. Sir, actually this 6MP, I think, sir. And
6MP is not for UGT1. What is the enzyme that is usually checked for 6MP?
Sir, exactly.
TPMT.
So TPMT is checked, not UGT1A1. So even nilotinib is another very common drug in patients with occult Gilbert syndrome. They can have massive indirect hyperbilirubinemia when it is started. So in clinical practice, many times when nilotinib is started, normal enzymes and indirect hyperbilirubinemia, go and do an NGS for the Gilberts, you'll be able to pick up the enzyme deficiency.
Yes, sir.
because of mutation. Patient, this is case scenario 2. This patient had a very small tumor. It has been reported as periampullary carcinoma.
Yes, sir.
T2, T3N0. Patient has been sent to you after a Whipple surgery. What adjuvant therapy will you?
Sir, adjuvant therapy, sir, we can give like gemcitabine and cisplatin.
Are you not interested in asking your pathologist anything else before deciding what adjuvant to give in periampullary tumor?
Sir, any margin positive disease like or any R1?
How do you classify periampullary tumors?
Sir, it is like, sir, intrahepatic, periductal, and distal, sir.
Is that how you decide what chemo to give?
No, sir. Sir, in this actually, like if there is a mucinous component or not, we have to discuss, sir.
So like, you don't want to know whether it's an intestinal type or a pancreatic.
You want to know, sir? Yes, sir. Yes, sir. So intestinal type can have.
Intestinal type, what adjuvant chemo will you give? If it is pancreatobiliary type, what chemo will you give?
Sir, like if it is intestinal, we'll prefer FOLFOX. And like if it is like pancreaticobiliary, Gemcis.
You give Gemcis? In your center, adjuvant is Gemcis in adjuvant, or what else you give? You give gemcitabine, or what are the various regimens used in adjuvant for pancreas and periampullary?
Sir, gemcitabine, capecitabine can be used. Then like modified FOLFIRINOX is also an option.
Okay, case scenario 3. This patient has multiple metastasis.
Yes, sir.
And what will be your drug of choice? Sir, this patient has extrahepatic, a large lesion in the bile duct, which was intruding into the periampullary lumen. They have done an ERCP, they have stented, and they have biopsied.
Yes, sir.
So this is a cholangiocarcinoma. CA19-9 is 15,000. Yes, patient has liver metastasis, lung metastasis, 41-year-old.
I would like to discuss with the patient the option of immunotherapy with the chemotherapy, sir. I would like to prefer. There are two options.
What immuno and what chemo?
Sir, one is we can either go for durvalumab plus gemcitabine and cisplatin, or we can give pembrolizumab also.
So this patient is also having, let us say, instead of the bile duct, now patient is a GB carcinoma with extensive.
Yes, sir. Sir,
does it vary? Does it differ, or will you be giving the same regimen?
Sir, in both the Topaz trial and Keynote 966, both they included GB patients also.
So if you have a cholangiocarcinoma, ductal cholangiocarcinoma, you have a case of gallbladder CA, and you're going to use Durva with Gemcis. Is the benefit across all groups, or which group seem to be benefiting more?
Sir, cholangio.
You're going to be spending a lot of money. So cholangiocarcinoma versus GB carcinoma, you're using Durva with Gemcis.
So the GB group did not benefit much from immunotherapy.
So subset analysis did not show. So benefit is predominantly for the cholangio group. Yes. Okay. Last question. You have a patient with a liver lesion. The liver lesion was the reason for jaundice. It's a huge, large liver lesion with multiple nodes outside in the hepatic periportal area. Okay. Yes. So and patient has chronic liver disease.
Yes, sir.
So what's your approach for this patient?
Sir, I would like to do a triple phase CT or MRI to rule out HCC.
Triple phase contrast CT says that there is an enhancing lesion in the liver, suggestive of hepatoma.
Yes, sir.
Biopsy, yes. Biopsy, no.
Sir, already since cirrhosis background is there, then arterial phase wash off and like portal phase this thing is there. So characteristic of HCC, you can take it as HCC.
Alpha fetoprotein is 10.
AFP actually, sir. AFP,
What
then we
are the hepatocellular carcinomas where AFP can be normal?
sir, fibrolamellar variety sometimes can be normal.
Any other tumor marker is there for
Puka, sir.
So PIVCA can be done. That it also has a tendency for both predictive as well as following up of treatment. What are the indications for biopsy in HCC?
Sir, means one is, sir, if there is a means suspicious lesion on, there is no background cirrhosis, but there is a liver lesion with the indeterminate imaging findings. So in that case, we can do. Otherwise, like there is a liver lesion, but if the patient's characteristics are unlikely for the patient to develop an HCC.
What other intrahepatic lesion other than HCC can be there?
Sir, one can be a solitary liver mets from somewhere else, or can be a
CT has not shown anything anywhere else.
Can be a large hemangioma also sometimes patients.
Other than that can be picked up easily on CT and PET. What else?
Then can be means, sir, only these two are coming to my mind, sir.
What is the other tumor you told me is common in India? It's coming up.
Intrahepatic cholangiocarcinoma.
Any other tumor markers for intrahepatic cholangiocarcinoma which will give you a clue and then you would like to.
can be done.
So in patients where CEA and CA19 are elevated, AFP is not very much elevated, PIVCA is not very much elevated, but still there could be a lesion that is very vascular like HCC. When you have atypical findings, especially when the cirrhotic background is not there, these are some of the indications for biopsy of HCC. In the exam, they will definitely ask you about HCC. When do you biopsy a HCC? When you don't need to biopsy a HCC? What are the, you have a American liver study group criteria which says when you need not biopsy a liver lesion and you can directly diagnose as HCC and then start treatment. So above what value of AFP you'll be able to do that. Please go and read all that. Last question. If this patient turns out as a HCC and
Yes,
the patient, your patient has turned out as a HCC,
yes,
and what is one single factor which you will decide whether you are going to, which will decide your line of management?
So, sir, the BCLC staging.
BCLC is
liver,
C.
like PS and liver.
BCLC is C because patient already has disease outside the liver. So we are not talking about taste, stare, and all those things. So this is a metastatic HCC. Advanced HCC, what is your main criteria which will help you decide the type of treatment?
One is, sir, performance status and main portal vein involvement.
Why do you want main portal vein involvement in an extrahepatic spread of the disease? Are you going to give taste for him?
No, sir, no, sir. Only performance status.
You want performance status or you want some other comprehensive score? You don't want to look at the Child-Pugh score?
Child-Pugh score, yes, sir, Child-Pugh score.
It is Child-Pugh score which will decide if the patient is CPA, the patient is CPB, the patient is CPC.
Yes, sir.
Then based on that, you're going to decide. Why?
Sir, because in child A, still there is an option of in child C means, sir, usually patient there is a systemic therapy option is there. Some patients can in child B and all there is
okay, let's go one by one. Child-Pugh C, your drug of choice apart from best supportive care.
Sir, Child-Pugh C you can give atezolizumab, bevacizumab.
Child-Pugh C.
Child C, no, sir, only lenvatinib. If
the patient is Child-Pugh A, what are you going to give?
Child-Pugh A, then we can give atezolizumab, bevacizumab.
You directly select. Then for whom will you give? What is the other immunotherapy regimen?
There is option of, sir, nivolumab, ipilimumab. Then there is durvalumab, tremelimumab also.
So how do you decide between Durva-Tremi, the stride regimen, versus Atisobev in a child PUA?
Sir,
What decides?
portal hypertension, if it is there, then
So what is one immediate test that you will do for these patients to decide whether you go for Atisobev or stride regimen?
OGD and Doppler.
So you do OGD and then look for features of portal hypertension, look for varices. If that is there, you have to band it, clip it, and then only go. Otherwise, you can give Atisobev.
Yes, sir.
For patients who have portal hypertension and who are a slightly more borderline, you can go straight away for stride regimen.
Yes, sir.
Okay. And child PUB, you
About
take a case to case basis as to what you want to treat. Okay, that should be your answer. Liver will be definitely there in your afternoon section. You will have a HCC picture put up on the CT, so you have to know how to manage various forms of HCC. Okay.
Yes, sir. Yes.
Udiptia, over to you. And Vinayak.
Sure, sir.
Thank you, Krishna. It's a very good discussion. So we have, I think we have a very short on time, right? We have another 50 minutes to go. So my topic is to cover drugs. So I will start with the first speaker, Shiza Aishwarya.
Yes, sir.
So you can choose any drug. We'll flip through it. So you can stop any of the drugs which you wanted to start taking.
Yes, sir. I'll do the first drugs.
Go ahead. No issue. We'll have one more option, but yeah. So usually, just to briefly summarize students that this is bare minimum you have to answer for any patients who we give the drug to you. So what is the group of class of drug it is?
Cisplatin belongs to platinum group of drugs, sir.
Okay. How does it work?
Sir, it causes DNA intrastrand and interstrand cross-linking, which causes DNA damage and apoptosis.
What are the doses which are in the clinical practice you know of?
For 3 weekly regimens, we use 100 mg per meter square, and for weekly, we use 40 mg per meter square.
Okay. So what are the major toxicity?
Sir, it belongs to the high emetic protocol. So nausea, vomiting, and then nephrotoxicity, neuropathy,
What kind of neuropathy it has?
sensory neuropathy, sir.
Hmm? What is characteristically described it is? But what kind of pain it is described?
Is, um,
No, issue, no issue.
co-
This is okay.
When
So
stopping.
what are the precautions you're gonna? A few things you missed actually.
uh,
Other toxicity, ototoxicity, and
Sorry, sir. So it can cause cytopenias, neutropenia, thrombocytopenia,
not
and
predominant.
ototoxicity, sir.
So what are the precautions you have to take during the administration of cisplatin?
Sir, high emetic protocol should be followed. Uh, we give a 4 drug regimen, dexamethasone 12 mg, MSit 8 mg, and then Apricap 125 day 1 and 80 mg day 2 day 3, and then also olanzapine, so 5 mg day 1, and then day 2, day 3, day 4, and hydration should be given, sir, with
So is there any role of giving? What is the role of giving all those electrolytes?
Sir, it is to prevent any acute kidney injuries.
Okay. What kind of injury this causes? Cisplatin causes to kidney?
Uh, it, um, it can cause elevation of creatinine.
More than that, we actually correct it every time, no?
Hypokalemia,
Why? Where is the site of absorption for most of the electrolytes?
the tubular injuries.
Okay. Next slide, please. Please go to the next slide. Yeah. Again. Just one minute. Just to show the slide, previous slide, the answers. Just to tell students. So these are the things which we expect you to answer. But if we can build on it, it's good. Next, any drugs you want to choose? A MAB, targeted therapy, anything?
Sir, anything, sir.
Okay, we'll go for trastuzumab. So, what does class it comes in?
Sir, it is a HER2 anti-HER2 monoclonal
Class
antibodies.
of drug. Class of drug. What is class of drug?
It's antibodies.
Okay, maps. Maps or
Monoclonal
biologicals.
antibodies. Yes, sir.
Biologicals. Mechanism.
Sir, it binds to HER2 receptor and prevents HER2 dimerization and the downstream activation of the PIK3 map, and it inhibits that, and also it causes antibody dependent cytotoxicity.
Okay. What is the dose?
It is given at 8 mg per kg as loading dose, followed by 6 mg per kg as every 3 weeks.
What are the precautions you have to take during the infusion of trastuzumab?
Sir, baseline you have to check for the EF, the echo should be done, sir. And sir,
How is given? In what formulation it is given?
it is given as a IV infusion, sir.
Okay. So what is the toxicity of trastuzumab?
Main toxicity is it causes a cardiotoxicity. Cardiotoxicity, sir. Type 2 cardiotoxicity, sir.
Okay. So type 2 is what? Type 1 is what?
Uh, Type 1 is it is caused due it is irreversible and is caused due to myocyte death, sir. And type 2 is more because of the HER2 receptor blocking in the myocytes. And
What is it called? Is it a dysfunction is type of conduction disabnormality, or what kind of abnormality it will be?
it it causes it causes I mean reversible LV dysfunction. It affects
What is
the
that called
signaling
usually?
in the cardiomyocytes.
Yeah, correct. You're right. Reversible, temporary, transient, myocardial contractility thing. What is that called otherwise? In yes, someone has mentioned it. Stunning. So
Stunning.
cardiac stunning it causes. So when do you want to stop? At what change of EF fraction you will change? Stop it or
Uh,
withhold?
Sir, we hold if EF drop is more than 10 percentage from the baseline, or if it is less than 50%, or if a patient develops symptoms of heart failure, sir.
Very good, very good. The last part is very important. It is not upon EF only, it is based upon the symptoms of the disease. Okay, fine. We'll go for next student. Sir, Krishna Kumar, sir, can you take the question? Sir, I only could.
Yeah. No, just I wanted to see there are specific ESMO guidelines, Dr. Aishwarya. I think just go back and see. I think most of the initial guidelines said absolute ejection fraction less than 50% and the drop of more than 10% from baseline, and symptomatic heart failure. But I think it has now become 40%. Just please go and check it. But yes, in my practice, I use 50% as a cut line. But just go back and see. So this is about cardiac remodulation, okay? Basically, cardiac stunning and cardiac remodulation is affected in type 2, whereas in cardiac damage, myocyte damage due to free radical injury occurs in type 1.
Okay, sir.
So that is the precise answer you should give to the examiner. Okay? Please.
Okay, sir.
Vinayak, you want to go down something else to ask? What are the other spotters?
Only drugs I have, sir, actually. But if you
Yeah, some other drug, the next candidate can come in.
next
Yes.
candidate, you can choose a drug for him, sir.
Can you just go down? Can you just go down? Yeah. What was the previous? Sorry. Yeah, you can. I think we'll go to that. Who is taking this?
Sir, me, sir.
Yes, Sriram.
Sir, osimertinib is actually a third generation anti-EGFR TKI, sir.
What is the dose used?
80 mg OD, sir.
What are the side effects of osimertinib?
Sir, one is like it can cause diarrhea, can cause ILD, can cause QT prolongation, mainly, and some hepatotoxicity also is documented.
You have started a patient on osimertinib, and after 6 months, you found the patient is CR. This patient is 83-year-old. with other comorbidities, unfit for chemotherapy or any other therapy. At
Yes, sir.
1.5 years, for some reason, with mild cough and other things, you go and recheck. There is no much ILD, but the
Yes.
lesion has slightly progressed in 3 or 4 places. So now they say there is a progressive disease. Patient is not willing for further chemotherapy or amivantamab or any of those kind of drugs.
Yes, sir.
What would you want to do? Is there any data to increase the dose of osimertinib because he's tolerating
Sir,
160 milligram of osimertinib in oligoprogressive? Is there any data?
sir, I'm not aware.
Please go and read. Second point, second case scenario. You started a patient on osimertinib,
Yes, sir.
80 milligram. Patient is doing very well. Okay.
Yes, sir.
Now, that time you had the EGFR mutation, you didn't have enough. I will give you 2 scenarios. You have a patient with EGFR positive exon 21 mutation. PDL1 is 50% in the same patient. Immunotherapy first or
Sir, always if targeted mutation is there, then we go ahead with osimertinib first.
very good. So you go with always a targeted first and the immunotherapy comes later.
Yeah.
So
Yes.
at 14 months, this patient starts progressing.
Yes, sir.
And now is not willing for chemotherapy. He says, I'm okay for immunotherapy. Do you have?
Sir,
You're going to start pembrolizumab in this patient now at 14 months after giving Tagrisso.
Sir, usually second line immunotherapy is an option, but single agent
My question is,
yes,
will
sir.
there be any additional toxicity of giving immunotherapy after osimertinib?
ILD risk.
What else?
Then
let us say you have a patient with let us say you have a patient who's on geftinib.
Yes, sir.
You have a patient on afatinib, you have a patient on osimertinib. All of them have high PDL1 expression.
Yes, sir.
So amongst these 3 scenarios, where are you more worried about increased immune-related side effects? First generation.
Sir, third generation.
Okay, go back and read
Yes,
about osimertinib and what is the immunomodulatory effects of osimertinib beyond EGFR inhibition, and what is the interaction of giving immunotherapy after giving Tagrisso for a patient.
Yes, sir.
Okay. Vinayak, any other? Can you just move down? We'll pick up one more. Yeah, what was that? Sorry, the previous one. I think we can have something on lymphoma. That's more interesting. It's my area. Okay. Scenario DLBCL on RCHOP. Okay, excellent. Yes. I think we'll go to the next candidate. Who's the next candidate?
Yes, sir. Sir, me, sir, Anisha.
Anisha,
Yes, sir.
please
So,
enumerate. You have
yes,
a
sir.
patient with CD20 positive DLBCL. You
Yes,
have
sir.
to tell me, how are you going to convince this patient to get rituximab? This patient says, I have borderline affordability, madam. Do I really need to take rituximab? So how are you going to convince this patient in real time about the benefit of adding rituximab? It is a patient with stage 3 DLBCL.
Yes, sir. So I would explain to him that this biological agent has
Not
is
about the
targeted.
mechanism of action. What is the benefit? Straight on the point. How much of survival benefit are you giving by adding rituximab? And on what trial are you telling me this?
Yes, sir. So survival benefit is there with DLBCL for DLBCL with the addition of rituximab. It showed a OS benefit as well as a progression.
Fine. Numbers. How are you going to tell the patient? You have to convince him he has to go take a loan and come now to get rituximab from you.
Exact number I'm not able to remember, sir.
Which trial brought rituximab into practice? All of you, please go back and read some amount of historical evolution of medical oncology. You have to know why rituximab came into practice. What is MAPTERA International Trial, MINT trial?
MAPTERA and MINT.
What is the
Mint
GALA
and
trial?
MAPTERA.
How
Mint and
did
MAPTERA, sir.
the so what was the survival benefit across? Yeah, from stage 1 to stage 4, what is the benefit of adding rituximab? So you have that in elderly as well as the young patients, at least 2 or 3 trials which showed definite survival and decrease in the hazards to progression. So you have to go and read about it. Okay. Now, what are the mechanisms by which rituximab acts?
Hello, sir.
What are the mechanisms of action of rituximab?
Yes, sir. So, rituximab is anti-CD20, sir. It blocks the CD20 receptor, sir.
Fine. What else?
It also
So the anti-CD20, and how does it cause cell killing? That's my question.
it has both antibody dependent cell cytotoxicity as well as complement dependent cell cytotoxicity, sir. So in that mechanism, the targeted
Accepted.
cell
Next question. What is the dose of rituximab in DLBCL?
375 mg per meter square, sir, given every 3 weeks with in combination with chemotherapy, sir.
What is the dose of rituximab in CLL?
Well,
What is the dose of rituximab in CLL in BR regimen?
so your voice is breaking, sir. Just
Is
1
the
minute, sir.
dose different?
Sir, I'm not able to hear you, sir.
You have different dose of rituximab for different indications. What is the dose of
CLL dose,
rituximab
sir,
in CLL?
Sir, in CLL dose is higher, sir, 500 mg per meter square, sir.
Why?
Because of the dim CD20 expression, higher dose was used in the.
Good, very good. What are the complications of rituximab you will explain to the patient before starting anti-CD20 rituximab antibodies?
Yes, sir. So,
What are the
before
toxicities
starting,
of rituximab?
yes, sir.
Apart from infusion-related reaction,
Yes, sir. Before
patient did not
starting,
have any infusion-related.
sir, before starting the regimen, I would check for hepatitis B infection, sir. Other toxicities is that in with rituximab is a lymphopenia that can happen, sir. So increased risk of infection has to be explained to the patient.
What else? Which is a kind of a class effect for most of the mAbs. Can there be any lung?
Fusion reaction, sir, because of the monoclonal.
Can there be any lung toxicity?
Yes, sir. Yes, sir.
Rituximab can cause ILD also.
Yes,
Okay?
sir. ILD. Yes, sir.
So many of these drugs, monoclonals have, and then progressive multifocal leukoencephalopathy due to other
Leukoencephalopathy.
opportunistic virus infections you should remember. Okay. So how do you screen for hepatitis B before starting any anti-CD20? What are the blood tests you ask for, Dr. Anisha, in your OPD?
Yes, sir. So first I would ask for HbsAg level, sir.
Negative.
Then anti-HBE.
HBE.
C, sir. C, sorry.
Anti-HBC. What is that C?
Core, sir. Core antibody.
Where do you
Against
get
the core.
HBE? Where do you get HBeAg?
Rapidly multiplying
It's in the active phase.
viral phase. It can be there, sir.
So you don't expect that as in the occult infection, right?
Yes, sir.
So at least you have to do a HBsAg and anti-HBcAb.
B. Yes,
so core
sir.
antibodies, you have to check if core antibodies are still there in the blood. Even though anti-HBs is negative, if core antibodies are there, you may have to look for the viral load, whether there is a small percentage of viral load going on, and then you'll have to treat that and then only take the patient for rituximab. What are the conditions where you give rituximab maintenance, Dr. Nisha?
In relapse setting, in patients with marginal...
Relapsed what? In DLBCL?
Yes, sir. In DLBCL, follicular lymphoma.
So in follicular lymphoma, you give only in the relapse setting?
No, sir. In first line setting, in
No, people don't drop the answers in the chat. She's getting distracted. So keep the answers to yourself, please. Yes, Anisha, please go ahead.
Sir, in first line setting, I would give for follicular lymphoma, sir. The for in recurrent setting for DLBCL, we can offer rituximab, sir, as a maintenance. Then for mantle cell lymphoma also, sir.
In the no, in the relapse setting, you want to give rituximab maintenance and DLBCL.
Yes, sir. First line setting, the survival, I mean, OS was not there, sir. So I would.
So in for relapse DLBCL, what is the treatment for? No. For DLBCL relapse, what is the treatment of choice? If a patient with DLBCL is not related to rituximab, no, I'm just generally asking you. If you have a patient with DLBCL,
yes, sir.
2 years follow-up has now relapsed, what's going to be your single line treatment plan for this patient?
I would like to go for salvage chemotherapy, sir.
Very good. And then do what?
Auto BMT.
Auto BMT. And then you want to give rituximab as maintenance post BMT?
No, sir. As in if auto BMT was not. Yes, sir. Sorry, sir.
Yeah. So don't make that mistake. Okay. So if you say that, then again we are missing. So in primary setting, high risk DLBCL, there are a few trials which have tried lenalidomide or rituximab in the maintenance, which has shown some progression-free survival benefit, but still it is an institution to institution practice. It is not straight away the standard of care. Okay. Rituximab, you should definitely know everything for all students, because I think like water, people use left, right, and center. So please learn that well. And most of the patients who are on maintenance rituximab should be vaccinated against opportunistic infection, against capsular microorganisms. So pneumococcal vaccine is very important. Please keep that also in mind. You'll have to mention that to the examiner. Uditya, I think I'm done with my questions.
I think we are shooting time. I think we have to give credit to the students for very well answer questions, but there is always learning. So we have to be focused. Thank you.
Yeah, all the three of you did well. Actually, you have all answered confidently. So I just wish you guys do the same way in the exam also. Okay. I always say that when some question is suddenly asked to you and you have blank, just gulp some, you take some water or take some time to just think for a few seconds and then calmly please answer. If examiners are throwing questions at you, doesn't mean that you need to give back answers at the same speed. Just think a little bit and then try to answer. Okay. Uditya, over to you.
Sure, sir. Dr. Munir, are you there? Thank you on behalf of AMPOC, Dr. Bobbin sir, and me and Dr. Munir, we have coordinated this session. Thank you so much, KKR sir and Vinayak sir, for giving the candidates and the exam going participants some flavor of the practical exams that are coming up next month. Thank you so much. I think we'll close the session with this.
Thank you, sir.
Bobbin sir, are you there? I think sir is not there, so we'll close the session then. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you, sir.